Hello colleagues, today we'll be discussing a case of a 57 years old male who complains of fatigue for the past few months. This was the ECG that was done when he presented to us. Now what we can see on the ECG is that there are some findings which are pretty obvious and we need to identify them to reach to the diagnosis. Now let's start from the QRS complexes. Well, we can see that these QRS complexes are broad and that is marked by the arrows. Now, when these complexes are broad, then this signifies that he might be having some bundle branch block. And now there are two types of bundle branch block, right bundle branch block or left bundle branch block. So what does this signify? This is suggestive of a right bundle branch block. The reason is that there is a QR pattern along with a increased width of more than 120 millisecond of the QRS complexes, and there is a delayed upstroke of the S wave in lead V6. So all these findings are correlating well with right bundle branch block. Now this doesn't end over here. We have to also see some other things. And first of all, for that, we have to identify the P waves. Now we can clearly see P waves somewhere, and at some points we have to identify and take them out. And I have marked these P waves with the arrows to make it easier to understand. Now what we can see is that these P waves are pretty much on time. So there is no variation in the PP interval. The rate for this gentleman was 88 beats per minute. And now this is something important when we'll discuss the ventricular rate. Now let's go and see the ventricular rate. It is again pretty regular, but the only thing is that these are broad, as discussed before. The ventricular rate is 57 beats per minute. Now we have seen that although these are regular, but the atrial and the ventricular rates, these are not equal. So this means the atrial rate is more than the ventricular rates. So this doesn't goes in the favor of a sinus rhythm, because in a sinus rhythm there is a one-to-one conduction and each P wave should be followed by a QRS complex. So the reason now is why the ventricular rate different from the atrial rate. We have to identify that reason. The reason for this is the AV dissociation. This means that this is no synchrony going on. The A and V are being dissociated. So does this have any significance, or does this correlate with some diagnosis? Now let's define the points which we have discussed so far. After discussing these points, we might be able to reach to some diagnosis. So let's start with the PP interval. So these are regular. The RR interval are again regular. The P and the QRS complexes are not associated. This means there is a dissociation present. Now the P waves are more in number than the QRS complexes, and these are being marked by these dotted circles. The purple one being the P waves and the yellow one being the QRS complexes. So obviously these P waves are more than the QRS complexes as seen by these dots. So we have checked in all the parameters which we have discussed. So does this suggest anything? Yes. This is suggestive of a condition called third degree AV block. Now let's discuss what does this third degree AV block is. Third degree AV block is a condition in which there is no conduction through the AV node, which ultimately leads to the dissociation of the atria and the ventricles. For a sinus rhythm, every P should be followed by a QRS. Now this video over here is showing a normal healthy sinus rhythm. We can see that every P or a QRS, they are in synchrony. Okay, we can clearly see over here. So the atria contract, the condition travel downs, and the ventricle contract. So this is a normal sinus rhythm. In the case of a third degree, this will not be present. So there is a complete cutoff between the atria and the ventricles. This condition is also called a complete AV block. Now the block can occur at many levels. So this is basically a diagram which shows that how a third degree occurs. So this part of the heart beats on its own, and this area has got no influence by this area, and this beats on its own. The conduction block can occur anywhere in the conduction system, right from the AV node to the bundle branch. So I have marked the normal anatomy over here. This is the area of the AV node. The bundle of his is in the septum over here, and the bundle branches right and left are being seen over here. So whenever the block occurs at the level of AV node, which is being marked over here, then this will be a complete AV block at AV nodal level. For a block at the bundle of his, it is right over here. Okay, and the bundle branch block, it has to be a complete transaction at anywhere in the conduction system at the level of bundle branches, and then usually there is a kind of escape from the other bundle. It can be either right bundle or the left bundle, so there has to be some escape going on. So the QRS complex can be narrow or the broad for a third degree, and it is not the rule that the QRS should be broad. However, in our case, we saw that these QRS complexes are broad, but sometimes with the narrow QRS complexes, the third degree AV block is still a possibility. So this is the pathophysiology of how it occurs and how this produces a narrow or a broad QRS complexes. The main problem is that there is a dissociation. So this area has got no influence over this area. Etiology. So what can be the causes for these third degree? We need to identify these causes before we want to treat the patient. So it can be because of myocardial infarction. It can be because of age-related degenerative conduction system disease. It can be because of the drugs like beta blockers or calcium channel blockers or some other drugs. Infections can also cause these AV blocks, and inflammation like sarcoidosis is an example which is commonly seen in young individuals, and sarcoidosis can cause this AV block, especially the granulomas when they settle in the conduction systems, and metabolic as well. So these are some common causes for a third degree AV block which we need to identify depending upon the case. Now, the treatment is usually not that much. There is very minimal role of a drug therapy in such cases. These can be used, however, but just to maintain the life and to maintain the heart rate and the blood pressure. One example of these is inotropes or theophylline can be given, but they have very minimal role, and mostly they have a bridging role, because until you decide the treatment options, you just need to maintain the heart rate with these drugs. Well, if there are reversible causes, as we have discussed before, then just observe the patient when the condition settles down, and ultimately these AV blocks also. So we can put a temporary pacemaker in such patients. And in those cases in which there is no cause found, then the definite treatment is a permanent pacemaker, which is being shown over here. And this is the only treatment that has been recommended for the patients with irreversible third degree AV block.